In fact, I was told when I started chronic pain management, I was told you're good at regionals, so you will be a good pain specialist. I was rather doubtful, and rightly so, because 10 years ago, I did a bungee jump, literally as well as figuratively in professional life. I was a very comfortable pediatric anesthetist. From there, I went into the unknown pain management, which has a very different philosophy. So in chronic pain management, the efficacy of block is far more important than the other considerations like how quickly you do it, how neatly you do it, or what are the other fallouts of that, minor fallouts of the block. And patients come with a lot of hope. When you see chronic pain patients, it's something like a reiteration to human spirit. They would have suffered 10 years, 15 years with the kind of pains that you and I cannot really imagine. They are really, really suffering. But yet, when they hear there is another doctor, they will come up with hopes. That is human spirit, I think. It never gives up hope. But when they come with hope like that, you have no business to disappoint them. You have to lay your cards on the table. And when it comes to procedures, we owe it to them to eliminate operator errors, technique-related errors. And the regional anesthesia for chronic pain is very different. There are many new techniques which I never did as an anesthetist. And indwelling catheters techniques which we use in anesthesia, maybe they last about 3 days, 4 days, 5 days. But in chronic pain, they may last for something like a month in exteriorized catheters. In cancer patients, they may last much longer. And then there are implanted systems which will last years. So confirmation of efficacy is mandatory. So as I was saying in my previous talk, I will use image guidance with dye spread, I'll use nerve stimulator, I will use USG, and if something else comes up, I will learn it. Like Dr. Chakravarti was saying, we are beating Alzheimer's by learning new techniques. That's the way to go. So the new techniques, unlike the regional anesthesia which targets nerves, pain management targets all pain generators. This may be a joint, this may be a bursa, this may be a muscle, it could be a tendon, etc. Brings in a whole new variety of procedures. And again, to harp, confirmation of accuracy by all these things. Many times, it's the patient who tells us. When the nerve is near his pain generator, he'll say, hey, that is my pain. So he's a confirmator, actually. So the nerve blocks of the central neuraxis, we have epidurals. We do midline epidurals as an anesthetic epidural at cervical and caudal levels. But at the lumbar level, it is usually transforaminal approach. Spinal, there is hardly ever use of spinal except for intradural drug delivery systems. Peripheral blocks, it may be a sympathetic block, it may be a somatic block. The sympathetic may be stellate, lumbar sympathetic blocks, celiac, superior hypogastric, ganglion impar, etc. The somatic blocks can be major nerve plexuses, brachial lumbar plexuses, or individual nerves. Epidurals can be, the name epidural does not mean the same thing. It's usually interlaminar only in cervical region. Lumbar and thoracic, it's usually transforaminal. So why do we prefer a transforaminal? Because most of the pathologies or pain generators may lie in the anterior epidural space, like the disc. Disc is an anterior epidural space, structure. Whether it is coming out like this or it's just an angry bubble here, it's an anterior epidural which will help them. Epidural space is not a simply contiguous concentric space. It has got compartments of posterior, lateral, and anterior. These have been described well. but I haven't given you the reference here, but they have been described. So spinal canal stenosis, another pathology, it will have a combination of anterior epidural problems and posterior epidural problems like the ligamentum flavum buckling or the facetal capsule coming in to form a facetal cyst. So much so, the canal becomes a narrow chink. So again, it is an anterior epidural that helps. In failed back surgery also, the scar tissue often occupies all these areas like this, and again accessible only to anterior epidural. Sorry. Not all epidurals that are given in post-operative, post-surgical back patients are simple. You have metallurgy sitting here like this. This is the tip of the iceberg that you see. This is surrounded by callus, which does not allow needles to come in. So quite a lot of considerations in the blocks which are done for chronic pain of the back. The transforaminal epidural comes in this direction here. This is the midline epidural approach that you take. The dye spread usually is like this. If you see a central spread, you will have to wonder about a dural tap. So these are the approaches, like your needle comes in here like this for transforaminal epidural, whereas it comes in this direction for the interlaminar epidural that you do. So we use ultrasound as a guide to the epidural depth assessment. Dr. Gopal has already touched on it, but this becomes very relevant to us in cervical zone. This is the spine, this is the facet, transverse process, this is the spinal space. You can even see the blood vessels here. This is another one. This is the anterior epidural shine seen here. If you put a caliper like this, you can see this is the distance for the epidural space. When you have a situation like Dr. Silamban saying that you have the ligamentum flavum not fusing in the center, and you may not get a loss of resistance properly, nor the feel of a tough ligamentum flavum, it's good to know that you cannot go beyond 3.64 in this patient. So these are rough guides for us, which are very, very useful. Same thing is done in lumbar spine also. This is the posterior dura, this is the anterior dura. It helps a lot to know all these things. Here is a cervical epidural done, needle in here. The catheter has gone in here, and you can see that the dye is spreading here. This guy had a problem mainly in this area. So we wait till we push some saline, see that the dye spread comes in the problem area, and then only we stop. There is nothing done without dye spread confirmation. So this is the guy who was pre-block. He just could not move his head. Post-block, full flexion. Spinal in chronic pain is only for testing the response to drugs like morphine, baclofen, prior to intrathecal pump implantation. This is how we do an intrathecal pump. A needle is pushed from one space below. The needle travels like this in the soft tissues till it enters an epidural space at 2 levels above. This is to prevent a 90-degree angle to the catheter. The catheter is placed into the spinal level wherever we wish to reach it, and then we can see it by a dye spread like this. The catheter is connected, taken under the skin like this, tunneled under the skin, connected to a pump, and then implanted under the skin in the abdomen, after which all dose regulations are done with an external programmer, and all drug fills are done through this. This is what a pump looks like. This is where the drug filling is done here. This is one of my nurses who was trained for doing this. She's doing this at home for a cancer patient. Sometimes we may prefer many patients cannot afford an intrathecal pump. In them, we put in an epidural port. The port lies here, and an external pump comes in like this. This is the Braun easy pump, which is used in an external manner. So the sympathetic ganglion blocks, I have already reiterated which are those. But I would like to stress on one thing. Stellate ganglion block has always been done with image guidance. This is one place where ultrasound scores way above the image guidance. This is because the esophagus is, suppose textbooks describe esophagus as coming out on the left side behind the trachea. I am doing a study just now where I have seen out of 10 people, I have seen it coming out on the right side, which means when you put a needle under image guidance, we may well go through the esophagus. The needle may pass through the esophagus to touch the Chassaignac tubercle. So this is, and many times, this is the right side where we are not seeing the esophagus in this patient. This is at C6, where you see the Chassaignac tubercle like this. This is the longus colli. Your needle will come in like this and enter this area. I'm sorry I don't have a video of this. My computer conked off before I could collect that. So this also shows us that the distance available for putting in a needle is about D, that is 1.2 centimeter window is available to us. This is the esophagus on the left side. This is what is coming. This is not very easily appreciated in this, but if you ask a patient to swallow, it will come like a starburst here. So that means instead of having a space like this to here, the space is reduced to this much. So F is the space available for needle placement. It becomes, ultrasound really makes it very easy for stellate ganglion blocks to be performed safely. This is another example. This is an aberrant vein, which was not expected, which I would not know if I was doing it radiologically, but because of